We're now going to hear from one of the key new bodies in the national space regarding the health reform agreement that was signed, as Stephen Duckett mentioned, back in August 2011. The Independent Hospital Pricing Authority is the body established as what it says, an independent statutory body that is charged with setting the national efficient price for the way clinical care should be delivered. They've invented a thing called the NWOW, the Nationally Weighted Activity Unit, which is a unit of comparison that says we can compare an episode of mental health to an episode of cardiothoracic surgery to an outpatient visit. And the ratio of NWOWs contained in the complexity of each of those clinical interactions allow us to work out what the prices and indeed the funding that can be provided for clinical services in the system are. James Downie is the Executive Director of the Independent Hospital Pricing Authority, and he's here to fill us in on what's happening at a national level there.
Hi, and thanks very much for the invitation to speak today. As Rowan mentioned, the National Health Reform Agreement was signed by First Ministers in August 2011. However, it's worth noting that activity-based funding has actually been a requirement for Commonwealth funding of hospitals since 2008 under a National Partnership Agreement. But the 2011 agreement provided for the establishment of the Independent Hospital Pricing Authority, and we commenced work in very late 2011. Our products are a single national efficient price for activity-based funded hospital services. And in 2012-13, this covered acute inpatients using DRGs, emergency department services using urgency-related groups, URGs, and outpatient services using Tier 2. And from 1 July this year, we've priced services for subacute and admitted mental health, which is sort of the next step in our evolution. Along with a single price, we have a number of adjustments, recognising that the cost of service delivery varies around the country. So we have loadings for patients on the basis of their location, where they live, remote and very remote areas particularly. We have loadings for Indigenous patients, loadings for ICU usage, and loadings for specialist paediatric hospitals, to name a few. We also have a role in specifying costing, classification and data standards, and we obviously produce a national pricing model that's available to all to see. We have very detailed technical specifications. Transparency is one of the key drivers of the pricing authority in the work that we do. We've had a task that has been challenging and fraught with danger of defining what is in scope for Commonwealth funding under the agreement, so defining what is a hospital service, which we're just getting to the end of finalising, and will go to health ministers for review in June. And we have another role under the National Health Reform Agreement to assess cost-shifting disputes and also cross-border disputes if they arise. And to date we haven't had any, which is happy for us, but that role is there, and we are ready to act on that if a health minister lodges a complaint. When does this all happen? You may have covered this morning, but 12-13 and 13-14 have been transitionary years in which the total Commonwealth funding to each state was guaranteed and set at the levels prescribed in the National Healthcare Agreement. But from 2014-15 onwards, the Commonwealth funding is fixed by the national efficient price and the percentage of growth in services in each local hospital network. So that will really start to come into play from 1 July 2014. The national efficient price for 13-14 we released at the beginning of March, and will be $4,993, which is a 3.8% increase on last year. Of course, what is paid to you as hospital managers may be different to that. It'll be different in each state. and the agreement also allows for differences across LHNs. But the national efficient price that we set is equivalent to the mean cost of an activity unit, of a weighted activity unit. We had to index 2010-11 cost data was the most recent data we had available, and that was indexed at 4.7%, which has been a keenly watched number indeed. I was asked to speak about the future of the work we've got left to do. We've got two key pieces of work in designing new classification systems. We've launched and we're well down the track of building a new mental health classification system, which has involved input from all the states and territories, but also from clinicians and other people in the mental health arena, such as consumers and carers. We're also required to design a classification system for teaching, training and research, and make a recommendation to COAG by 2018 on if it's feasible to fund those services on the basis of activity. We've got a lot of work to do in reviewing our infant classification systems in outpatients and emergency departments. And we have the ongoing development of the ARDIG system and ANSNAP in subacute, which we take seriously, and that work is continuing. The other significant area which I want to touch on today is costing. Costing's always been a contentious issue in healthcare. The National Health Cost Collection, Hospital Cost Collection, has been around for now 16 years and is a comprehensive collection of costs, and in fact is considered world-class by many. But there have been questions, I guess, around national consistency, and significant improvements have been made on that over the last 3 years. We still have challenges in coverage outside of ED and admitted patients, but there's significant work underway that no doubt many of you will be involved in over the next few months to improve the costing, particularly in outpatients and mental health, and as we move into non-hospital located services, community delivered services, that's a big challenge for us as well. We're just finalising our strategic review of the NHCDC, which will be released soon, and that will almost certainly involve revising the costing standards and increasing our engagement with the sector. So I look forward to getting your input on that. That's what I had for today. So they're the key points, I think, for that we see as the big challenges moving forward. For those of you who haven't seen our website, we have a host of information there, from data specifications to costing standards, and through to the pricing model and all the price weights and things like that. So I'd encourage you to visit that, and if you've got any queries, we're always happy to try and help. Thank you very much.